Okay, we're going to go ahead and get started. So welcome to today's webinar on integrating behavioral health peer support specialists into crisis response. On behalf of the academic training to inform police responses, I want to welcome you to today's webinar. We have an incredible group of speakers, as you can see here, listed on your screen, and I'm going to go through their bios and introduce them here in just a few minutes. So, my name is Mike Hatch, and I am from Policy Research Associates, part of the academic training to inform police responses, and I will be your moderator for today. The academic training initiative was born out of the recognition that as communities examined how they respond to individuals with behavioral health conditions and disabilities, it's important that we learn from practitioners about best practices in the field, and also from researchers who are working to build the evidence base on the effectiveness of those practices. My colleagues and I joined this effort from subject matter experts from Policy Research Associates, the ARC's National Center on Criminal Justice and Disability, and the International Associations of Chiefs of Police. And our lead on this project is the University of Cincinnati. Together, our team is building and delivering training, technical assistance, and companion resources that are centered around best practices in crisis response that are supported by research. Our goal is to support law enforcement agencies and their community partners in their responses to people with behavioral health conditions and developmental disabilities, and to ensure that these encounters are more effective and equitable, but also safer for both citizens and law enforcement officers. Today, you'll be hearing from several presenters speak on the role of behavioral health peer support specialists across the criminal justice system, and specifically their roles in crisis response. These speakers will highlight how peer support specialists are trained and embedded in teams of professionals tasked with responding to crisis calls in the community. They will also discuss how people with intellectual and developmental disabilities, we'll refer to it as IDD, might be integrated into similar peer support roles to enhance crisis responses to people with IDD. Just a couple of quick housekeeping things before we get started here. The preparation of this webinar was supported by the grant number you see here on the screen, awarded by the Bureau of Justice Assistance. The Bureau of Justice Assistance is a component of the Department of Justice's Office of Justice Programs. Points of view or opinions in this webinar are those of the authors and do not necessarily reflect the official positions or policies of the U.S. Department of Justice. As a reminder, that you'll see typically on the bottom of your screen a Q&A pod. So please submit your questions to the presenters in the Q&A pod. The presenters will address as many questions as time permits at the end of the presentation or the webinar for the day. The webinar is being recorded and slides will be disseminated in the days following the webinar. We have ASL interpretation available for this webinar. The ASL interpreters for this meeting are Dave Gratzer and Dwight Godwin. And if you find their names on your screen, the little three dots, you can click on the three dots typically in the upper right corner, and you can pin their video to utilize their skills. So live transcripting from Zoom is available. If you click Live Transcript CC, and then select Show Subtitles. Subtitles can be moved within the window and resized as you need them. With that, I'll introduce our first speaker. Chanson Neither is the Director of Policy Research Associates, PRA. In this capacity, Mr. Neither oversees a portfolio of criminal justice and behavioral health focused training and technical assistance initiatives for PRA. In his primary role as the director of SAMHSA Gaines Center for Behavioral Health and Justice Transformation, where he oversees all training and technical assistance activities for the center. Mr. Neither also serves as PRA's director for the BJA-funded Academic Training to Inform Police Response's national initiative to enhance police engagement with people with behavioral health conditions and developmental disabilities. Our next speaker is Patricia McIntosh. She's the Director of Community Safety and Wellness for the City of Hartford, Connecticut. In this capacity, she is responsible for leading projects aimed at improving the interrelated systems that serve the city's most vulnerable residents. The Office of Community Safety and Wellness is responsible for collaborative partnerships with community-based organizations, state and federal agencies, healthcare providers, and community members. These projects address issues of mental health, justice involvement, violence, housing insecurity, access to education, and many more things. In late 2020, Ms. McIntosh began working with the City of Hartford to support the development of a civilian crisis response team for nonviolent 911 calls for individuals experiencing emotional distress. In 2022, the HEART team launched, providing a tiered response using both co-response and community response model, which started in April of 2020 and continues to expand in development today. Our next speaker is Stephanie Perez. Stephanie's bilingual and bicultural, and she is a member of the Community Renewal Team, who serves as a peer recovery specialist on the Hartford Emergency Assistance Response Team, and you'll hear them refer to them as HEART Team. She has served on the HEART Team since it began in December of 2020. Most recently, she has been certified as a community health educator and a recovery support specialist. Ms. Perez exemplifies the role of a peer recovery specialist. She provides clients with a real-life understanding of what living in crisis and dealing with substance abuse is all about. Happily, she has been in recovery since Mother's Day of 2016. Additionally, Ms. Perez is a survivor of child exploitation, domestic violence, and human trafficking. Impassioned by this job, Ms. Perez believes that the CRT model works well because of the strong connection made with the clients. Ms. Perez meets the clients where they are, inspires hope, shows that recovery is possible by sharing her lived experiences. Leanne Davis is the Director of the Justice Initiatives at the ARC of the United States. She directs the ARC's National Center on Criminal Justice and Disability. She oversaw the development of the NCCJD's signature training, Pathways to Justice, and passionately works to establish NCCJD and the ARC's 650 chapter network as the go-to place for information on and training on justice and disability. The ARC's subject matter expert on topics of justice and IDD, she provides consultation to federal and nonprofit agencies and has provided guidance to the White House. Her mission is to ensure that people with IDD have a platform and the training they need to advocate for themselves, especially as citizens who are overrepresented in the criminal justice system. And Leanne's in Texas, and also joining us from Texas is Jordan Smelly. Jordan is a mental health peer support specialist and a person in long-term recovery from intellectual and developmental differences with co-occurring mental health challenges. Jordan defines his own recovery in relation to the opportunities available to present and educate the community on topics around supporting individuals with IDD. He prioritizes his ability to advocate for himself and others, as well as find robust resources to address ongoing issues that may present. Jordan has created and delivered various presentations and is involved in IDD peer support projects throughout Texas, including the honor of being selected to present at the NAMI Texas 2022 conference which was just this past November. Jordan is passionate about ensuring individuals with IDD can get peer support services necessary when they are ready to receive them. Those are our presenters today. And with that, I will turn it over to our first presenter, Chansa Neither. Chan?
Great. Thank you, Mr. Hatch. I appreciate that warm overview and welcoming and introduction of all of our presenters. Happy to be here today. As Mike said, my name is Chan Neither. I am a director at Policy Research Associates, and I'm very involved in the Bureau of Justice Assistance project that's supporting the webinar today. My job on the webinar today is to provide a brief overview of peer support across the sequential intercept model. And for those of you who may not be familiar with the sequential intercept model, I'll also provide a very brief overview of that model when we get to that point in the presentation. But let me first start by waiting for the slide to advance. There we go. Providing an overview just broadly of peer support and some of the evidence for the impact and the effectiveness of peer support that's supported by some of the research literature that's out there in the field. Broadly, when we talk about peer support, we're talking about peer support as an evidence-based practice, and it is one that has been proven highly effective in supporting recovery of people with behavioral health conditions who are also involved in the criminal legal system. Among the effects of peer support has been shown to increase engagement in treatment and recovery, promote a sense of hope and self-empowerment, improve social functioning and overall quality of life, and decrease both the frequency and duration of inpatient hospitalizations. And there are really two critical components to peer support. The first involves believing that recovery is possible for people with behavioral health conditions. Also, the belief that belief in the mutually beneficial relationship between and among individuals with similar life experiences. When we're talking broadly about peer support and peer support in general, requirements, I mean, that's in quote, but typically people who provide peer support services self-identify as a person in recovery from mental illness and or substance abuse and or trauma. When we're speaking about people who provide peer support specifically to veterans, the addition of military service is typically frequently also a shared experience. Similarly, when we're talking about people who provide family support, having a family member who's in recovery is also typically an additional shared experience. Now, when we're talking about people who provide peer support to people who are involved in the criminal legal system or in settings, in criminal legal system settings, individuals typically, I won't say have to, but should also have shared experience of having also been involved in the criminal legal system. About 3 years ago, Mental Health America put out a brief that provided an overview of the evidence for peer support. And among some of the impact that was demonstrated in that report, including the first two bullets, which we already talked about, a lower overall cost of services. And that's due in part to a greater utilization of outpatient treatment services that are less costly and less intensive. Increased engagement rates in treatment, improved quality of life outcomes, and improved whole health outcomes. We also know that peer support is support that is better able to engage people in caring relationships. It helps improve relationships between clients and outpatient providers, increasing engagement in those non-acute and less costly services on an outpatient basis. Can help decrease substance use, help address unmet needs, increase things like hope, empowerment, self-efficacy, and quality and satisfaction with life. And some research has found that those who receive peer support are more likely than those who do not to avoid returning to jail or prison, improve their community living standards or their general level of functioning, to reestablish family relationships or develop new social connections to people in their communities, and live and work independently. So I'm going to talk about peer roles, and I'm going to use the sequential intercept model as a way to talk about the various roles that peers can play in helping support people who with behavioral health conditions who are involved in the criminal legal system. And again, for those of you who aren't familiar with the sequential intercept model, this is the model, and this model depicts how adults with behavioral health needs typically move through the criminal legal system. It's a model that was developed in the mid-2000s by doctors Mark Munitz and Patty Griffin both of whom we've worked with very closely over the years, with this model. And we utilize this model at Policy Research Associates to guide pretty much all of the work that we do that's related to people with behavioral health conditions who are involved in the criminal legal system. Each of the intercepts of the intercept model represent a point of opportunity for diverting or deflecting an individual from the criminal legal system to treatment and supports. They also represent different parts of the criminal legal system process. And by understanding what the different components of the criminal legal system are, you can use the sequential intercept model as a tool to really understand where there are critical needs, critical gaps for support and issues that need to be addressed by using this model. So I'm going to use this model to sort of organize and talk very briefly about what some of the roles are for behavioral health peer support providers at each intercept. So at Intercept 0, we're talking about the community-based crisis response system, essentially. And there are a lot of different functions that peer support providers can provide at Intercept 0, including being part of general and targeted public outreach and engagement efforts, operating warm lines and crisis lines, serving on mobile crisis teams, working in crisis stabilization units and crisis respites, working as a peer navigator or peer bridger in hospital emergency departments, being on ACT teams, facilitating support groups, and other community-based services. At Intercept 1, this is the intercept that represents law enforcement. Peers can and are frequently and should always be involved with crisis intervention team training and other programmatic elements of a CIT program in a community. They can co-respond with law enforcement and community services, can help coordinate outreach and engagement efforts for people who've been identified at risk for rehospitalization or reincarceration. Intercept 2 represents the intercept that of initial detention and initial court hearings. Some roles that behavioral health peer support providers can play here are to help people process what's happened to them and prepare what's coming for next, particularly for people with behavioral health conditions who don't have a lot of experience with the criminal legal system, and even those who do. They can help explain the arrest, detention, and arraignment process, and throughout the process help to ensure that the individual feels safe and respected. Can also help give the individual hope that they can recover from mental and substance use disorders and cope with their criminal legal system involvement. Intercept 3 represents jails and courts. There are a variety of different roles that peers can provide. When we're talking about courts, one of the main places that we see peers providing peer support services and being part of the criminal legal system process is on treatment court teams. Peers can be an integral component of that team and are often included as an equal member of the working group that compromises the treatment court team in a particular community. Also providing peer support services, as I mentioned, on ACT teams, FACT teams, and peer support in jail and prison while people are incarcerated is becoming an increasingly widely used strategy to help support people while they are incarcerated, both in terms of providing mentoring for people who are incarcerated, facilitating support groups, and otherwise supporting people with behavioral health conditions who are in jail or prison. In Intercept 4, this is where we're talking about reentry. Peers can help provide peer support around reducing relapse and recidivism. During reentry, peer support specialists can help with treatment planning and system navigation. And when planning for discharge or planning for reentry is begun prior to someone's release from a facility, peer support activities can include helping prepare people to develop plans and identify resources prior to reentry into the community to ensure uninterrupted treatment and connection with the recovery community upon release. And finally, Intercept 5 represents community corrections. Peers can assist people who are placed on probation and parole with understanding and adhering to the provisions and conditions of their probation and parole, help balance such responsibilities with sustaining treatment and recovery, and can work with both the individual and the probation and parole officers to access resources and services, including housing, employment, and benefits. So with that, I will turn it over to Patricia McIntosh and Stephanie Perez, who are going to talk about their experiences in the city of Hartford, Connecticut with the Hartford Emergency Assistance Response Team. Thank you very much.
Just ahead of Patricia and Stephanie, I will let the folks know that in the chat, we will be putting 2 downloadable documents in the chat, and we're going to disable the chat for just a couple minutes for folks to grab those documents, and they can see them there. And the first one puts a really nice bow and package on what Chan just talked about, peer support roles across the sequential intercept model. That document was done by Policy Research Incorporated. And the second document is a Samsa Gaines document, peer support roles in criminal justice settings. Those documents are in the chat. They're available for download, and we'll disable the chat for just a few minutes for folks to grab those documents. Patricia, it's all yours.
Thank you, everyone, for attending today, and thank you very much for this opportunity to present to you the City of Hartford's efforts with establishing a civilian crisis response team and using peers in this format. We, the City of Hartford, see, I'm trying to use my controls that are not working, not sure why. Okay. All right, the City of Hartford is committed to creating a safe, humane, and comprehensive response to nonviolent emergency calls for service for individuals with emotional distress. And how we got here, I'll give you a little of the history, and then Stephanie will talk a bit more with us about the actual utilization of the peers in this program. So in the fall of 2020, the City of Hartford Mayor Luke Cronin and City Council approved and allocated $5 million to the development of a crisis response program. With this, and we were looking at establishing something in lieu of or in coordination with and collaboration with the Hartford Police Department. They're an advisory board of community representatives, and all of the public safety departments and our Health and Human Services Department was created. A project manager was put in place, and this team met for several weeks, several months, in fact, to explore the options that fit the culture and the demographics of Hartford. And I think it's very important to think about, what city you're serving and what you create fits the needs of your city. Recommendations were submitted to the mayor. A tiered response was determined in 2021. We put out an RFP, and then we began the process of integrating the public safety departments and the services together. A co-response collaboration was established this year with our youth services, and we already had a very strong co-response with our state regional mental health service provider for adults for more serious situations. So the most creative part of our program launch was in April 2022, earlier this year, with using a clinician and a peer without dispatching the police. And that is with the Community Renewal Team agency in Hartford, and Stephanie will talk more with you about that. Part of our unique approach to this effort was that the City of Hartford 911 call center dispatches the HART team. So some cities did not have that structure, but we put everything through our dispatch center. So just as they dispatch other public safety services, police, fire, and ambulance, they also have now 3 social service agencies that they can dispatch for mental health response according to what type of mental health need is presenting. There's a co-response with 2 of the agencies, and the community response, as I just described, with the Community Renewal Team. And the city itself also has a number of other social service agencies to care that can provide services across the continuum. I will briefly go into the description of what we have in place for adult co-response. We have a relationship with the Department of Mental Health and Addiction Services. Their mobile crisis team has been working with the Hartford Police Department since 2003 to deliver care to a very targeted client group of adults with severe and persistent mental illness and or co-occurring substance use, and adults in behavioral health crisis. So that relationship that was already happening with the Hartford Police Department and mobile crisis team really set a nice platform for adding additional services and having them integrated into the system. The areas of focus that Capital Region Mental Health Center provides is for long-term relationships with residents, Hartford Police Department, city hospitals, and they have access to a statewide service history, and they're able to manage the most complex care needs. So that was something already in place that was just enhanced through this process of evaluating the services that were existing and through the increased demand for mental health services in the Connecticut region. We also have Wheeler Clinic as one of our other providers, and they provide youth mobile crisis intervention services. So it's the same kind of mobile crisis team as Capital Region Mental Health. However, it's designated for youth, and they have a lot of expertise just for 18 and under. They're able to provide follow-up care. They have existing partnerships with some of our other service providers that were very key to what we wanted to establish. And so we created a link between them and our public safety departments as well. And the most innovative piece is the community renewal team, who created a department called the Community Response Services to provide services to adults in less acute emotional distress. We started out initially working with call types that included indecent exposure, loitering, intoxicated persons, and calls for assistance. We've already expanded the calls to include wellness checks, trespassing, panhandling, emotionally distressed people, and homelessness. Our current plan is to also expand to include substance use and overdoses. Clinicians and peer responders are the ones who are deployed by dispatch, and they conduct independent outreach as well. And then their areas of focus are crisis de-escalation and connection to services, including basic needs, employment, housing, and other services. Wraparound case management is provided, and often at the time of actual deployment, there's a clinical, because there's a clinician involved, there is a clinical assessment being done as well. The dispatch process is pivotal to assigning the right resource. I mentioned using our dispatch now to provide them with new resources. So the way that it's managed with CRT is that calls come from dispatch directly to a CRT dedicated phone line, and then they dispatch their team, and they utilize a police radio to communicate when they're en route to a call, when they're on scene, and when they're terminating a call. The radio also provides some direct access to emergency services in the event of an emergency. I wanted to provide a quick data overview from April through October. So for the 7 months that we've been operating the program, it's now been 8 months, but the details for November are being tallied. We have responded to 389 calls, not 800, 389 calls. 78% were without any kind of co-response. So that is no police involved, no fire, no ambulance, just the CRT clinician and peer going out to respond to a person in crisis, social or emotional crisis. The average response time to the call is under 15 minutes. There's no lights or sirens. They're not in a police vehicle or any kind of emergency vehicle. They are on scene within 15 minutes, and then follow-ups are arranged for about 35% of the calls. So they are also available to provide wraparound case management services, and they do that through following up and for about a third of the calls that are coming in. Most of the encounters that they make are under 20 minutes, and with 10% of those are with repeat clients. And oftentimes people ask, well, how many of those elevated to the place where you needed to provide some kind of other emergency response? And 7% have escalated on scene, which meant that there was a co-response called either for police or EMS or fire. The services that are provided are 56% substance use disorder and mental illness, 15% homelessness, 30% other. Client demographics, Sometimes people do not share, or where it's not recorded on scene. So these numbers won't tally to 100, but just so you can get a sense, majority female, 43% male, 37% Black, 30% white, 25% Latino. Staff demographics, right now there's a staff of 9, 89% female, 33% white, 67% non-white, and 34% Spanish speaking. I mentioned those demographics because I talked about having a program that fits your city. And just to mention that Hartford itself, Hartford, Connecticut, is a city of about 121,000 residents. And then 44% of those residents are from Spanish-speaking cultures. About 36 are from African American, African, or Caribbean cultures, and then 3% Asian and 13% white. So it's a very diverse city, and the demographics that don't match many other cities across the United States, in fact. So when we looked at creating the program for Heart Team, we wondered why. We thought, the question of why use peers came up. And so we use peers to help to reduce barriers to interventions and supports. We use peers to complement the role of the clinician. They are a positive role model, so they offer positive role modeling throughout their encounters. Our peers reflect the demographics of the community being served. And also they broaden the pool of responders to eliminate any equity concerns because they bring in more representation, and we know that the representation matters. With that, I'll transition to Stephanie. You're on mute.
There we go. Okay. Hi, everyone. We'll be talking about the peers, who we are, why we're unique, and how our lived experience supports the Heart Team. So peers are also known as recovery support specialists here in Connecticut. There is certification that is available through several community service agencies such as CCAR, the Connecticut Communities for Addiction and Recovery, AU, Advocacy Unlimited. There's also state certification that is available in Connecticut through the CCB board, where people can become a certified peer recovery support specialist. The unifying skills of the peer is to use our own lived experience to engage, support, and empower clients on their own recovery journey. Recovery is not only specific to substance use, it can refer to mental health, domestic violence, human trafficking, and other challenging experiences such as trauma, problem gambling, and eating disorders. Okay, so the most unique skills that we use and utilize during out in the field is our lived experience. And for me, my lived experience has helped me inspire hope and show that recovery is possible, bring awareness by educating people on what recovery is and the different roads of recovery, meet clients exactly where they're at, whether that's the pre-contemplation stage, contemplation, preparation, action, or maintenance stage. Show that recovery is possible. We allow connection. We break stigma by working with people with substance use and mental health, and we reduce judgment by connecting with our clients and showing them that this is not a hierarchy relationship. Okay, so as Patricia stated, we dispatch a clinician and a peer. The peer engages with the client, asks questions, builds rapport, shares lived experience, inspires hope, and reassures the clients that they're not alone during this process. It's a very scary process, as when we encounter people, they're in active crisis most of the time. The clinician conducts a brief biopsychosocial assessment to gauge the client's overall functioning. The clinician identifies the needs, and we work collaboratively with myself, the peer, to provide immediate safety planning on scene. On scene, we also provide a provisional plan of care that is created. And while we're creating this, we're including the client into this plan as this is their plan for their recovery journey. On-scene intervention is not where it ends. CRT also utilizes community health workers, which are CHW, and they provide ongoing case management by linking clients to community resources. After 7 months of being launched, our overall goal is to have all of our peers duly certified as community health workers to further enhance the care provided to our clients. So now I'll be going over a few of our success stories, things we've encountered over the last 7 months. I'll be going by the presenting problem, the intervention, the outcome, and how things went. So our first success story, we encountered a Hispanic male laying down, loitering, requesting assistance. Once we arrived on the scene, we found out that the client was in distress because he was homeless and felt there was no support for him. He made many comments saying, there's no shelter beds, I'm having issues calling 211. 211 is a system that we use here to support people in getting into the homeless system. So it's a very lengthy process, and sometimes clients get discouraged. So we support the client by making those phone calls with them. But for this particular client, he was completely discouraged and stating, there's just no hope for me. So as the peer that intervened, I connected with the client immediately. I provided him a next day appointment. The client followed up the next day, but he was completely adamant that recovery was not in his plans. I continued to follow up. I continue to build rapport, continue to share my lived experience, continue to demonstrate empathy. And during that process, I was able to help him secure somewhere to get his mail because due to him being homeless, he didn't have nowhere to get his mail. We were able to activate his health care insurance. We were able to get him a phone, provide him hygiene kits, and some food assistance. Thankfully, he was very grateful for everything that was provided. And during the process, I still continued to provide encouragement, connection, hope, and motivation. I had given him a 2-week follow-up appointment, and he had missed the appointment. I honestly thought that he was not going to re-engage since a lot of his basic needs were met. But thankfully, 2 weeks later, I received a call from him. And basically, he was thanking me for sharing my lived experience. He thanked me for being very persistent and very humble, and he felt that my story inspired him. Therefore, he had enrolled in a detox an hour away. And you're probably wondering why an hour away, right? So what was in his mind was, I need to stay away from triggers. I need to stay away from people, places, and things that will keep me from obtaining my sobriety. So we were able to continue working with him. We were able to link him to the methadone treatment center. And within 2 weeks, he was placed in one of our CRT shelter beds. Success story 2. So for this success story, it was a well-being check for a 35-year-old woman. The person who had made the call was the adult nieces. They were very concerned for their aunt's safety as she had not been heard from 3 days. And 3 days prior to that, the neighbors saw her in a verbal argument with her boyfriend that escalated to physical abuse. The nieces were very concerned due also to her relapsing about 2 to 3 months ago. She was now using heroin and cocaine. She was also very discouraged because she had lost her child through DCF. Those that don't know, DCF is the Department of Children and Family. So the nieces were very concerned also because the aunt was depressed. So during the intervention, what did we do? So immediately we called the co-response. When, like Patricia said, when we call co-response, we can request EMS, fire, or police. In this situation, due to the domestic violence concern, we called for a co-response with police without sirens. And when we say without sirens, it's because our main goal is to show the community that we're here to support, and we're here to be there for them, and we're trusted members of the community. I, as the peer, connected with the family, shared my lived experience with substance abuse, addiction, and my personal history with DCF. I shared how I was able to obtain my sobriety and how I was able to get my children back from the Department of Children and Family. During this process, we contacted the landlord who sent over a property manager who was able to open up the unit. The police was able to go in. And while the police was in, we were outside supporting the family, and thankfully the client was not inside the home. The police intervention ended, but ours did not. As the peer, I engaged with the neighbors to identify where the client seeks drugs at. I helped identify places where she frequents at to get her drugs, and I encouraged the family to carefully pass by these sites and see if they see their loved ones. Why engage with the community? Why engage with neighbors? You're probably asking, right? Well, I am the community. By that I mean I was once her and once in that community. They saw me at my worst. They saw me when I was down and had absolutely nothing. So they know exactly from what place I'm coming from. I'm not coming from a place to arrest because obviously police came on scene. I'm not coming from a place to point fingers or judge. I'm coming from a place of support and looking to support you to get to your next step. So the community felt very comfortable in helping us find where this woman was at so we can help her get to where she needed to. We had a second intervention because thankfully the family was successful and was able to find their loved ones. They immediately contacted myself as the peer. I immediately did some peer support over the phone. I shared my lived experience. I inspired hope. I shared my experience with DCF, and I provided her some hope that she could obtain sobriety and that she could get her child back, I'm sorry. She immediately broke down and agreed to engage with detox and inpatient treatment. So what were the outcomes? The outcomes were referrals to detox. Due to her complex drug use, we made it necessary for her to have a medical clearance prior to detox. We set that up with a local hospital that we have a relationship with. We explained what was going on and why we felt that she needed a medical clearance. The Heart team provided her transportation to the hospital for medical detox prior to the inpatient care. And I, as the community health worker and the peer support, I maintained a relationship with the hospital staff and the client. That way I can be able to support in a warm handoff into inpatient facility, which she did. And she did go to, I'm sorry. Success story 3. So this one was a male party wearing a hospital wristband outside asking for money. So once I'm seeing, a local person in the area identified that the client was in an apartment in a building next to the area where the team was at. That person was able to let us into the building. And once inside the building, the client's mother explained client's struggle with alcohol. The mother was highly concerned about her son's substance use, as he has made homicidal remarks towards mother while he's intoxicated. So during the initial intervention, we canvassed the area in search of the client. As the peer, I connected with the family and again share my lived experience and effort to inspire hope to the family. I am Spanish speaking, therefore I was able to connect linguistically and culturally with the family and also provide interpretation to the rest of the Heart team that was there with us. We were able to find the client. He was receptive to treatment. We did some referrals and we did some screening that was completed for detox and inpatient treatment. We immediately created a recovery support plan tailored to his needs. And we also used some harm reduction skills and helped him make a plan to reduce his alcohol intake. We also as well created a safety plan for mom to make sure that she felt safe. Our intervention did not end there. During the process, we continued providing coaching, mentoring, and anticipating next steps. I maintained a relationship with his mother as the son's request. I contacted a local detox to get client connected to treatment. And then client was picked up and transported here to our CRT office. We had him here. We had him screened and all set up to go to treatment. And then we Ubered him to a detox in which we have a good relationship with. I maintained involved with the family to assist in care coordination. But during this process, we noticed that something was off. We noticed that he couldn't keep his equilibrium. We noticed that he was slurring his words. We noticed that he was just struggling a lot. So at that point, we decided to transfer him back to the hospital and have him get a medical clearance. I was able to call the ambulance and request for him to be transported for a possible TBI or a head injury. It actually ended up working out great because the EMS provider who came on had actually encountered him 3 weeks prior and had informed me that he was assaulted by 3 individuals in which he had been hit in the head a few times. Therefore, the ambulance recognized him and was able to advocate for him at the hospital to get a CT scan to be able to rule out the TBI. While he was being ruled out for the TBI and being medically cleared, he was able to finish his detox in the hospital. We were again able to identify another treatment facility and coordinate the transition for hospital treatment. I continued to stay connected with the family for support. And lastly, he was completed treatment successfully and was discharged home back to his mom. So what lies ahead for the community response team? A few things. We would like increase in hours and access from 7 hours Monday to Friday that we do now to 13 hours, which is Sunday through Saturday. We would like professional development for all our peers and CHW to have dual certification for their roles. Ongoing skill development for the whole team. Expansion of calls. We plan on doing OD overdose calls within the next few months. And continuing to promote services as part of our emergency response team for the city of Hartford. There we go.
All right, thank you so much, Stephanie and Patricia. What an amazing amount of work that you're doing, and important work, and just listening to all of it, I'm inspired to think about all the different ways that everyone listening to this webinar right now is, considering how can we do that? How can we take a program on like this? So I'm sure just by seeing all the chat, there's a lot of thoughts around this. And now I'd like to talk a little bit about how we can incorporate people with intellectual and developmental disabilities into peer response when it comes to co-response. Let me see here, make sure I can forward the slide. And before I get started doing that, I just wanted to mention what we're talking about when we say intellectual and developmental disabilities. I do work at the ARC of the United States, and our primary mission through the ARC is to support, work with people with intellectual and developmental disabilities, and that is different from mental health conditions. So I just wanted to lay some groundwork on what IDD is, and I saw that that was asked in the chat, so we are going to talk about that now. So developmental disabilities are a group of conditions that, due to impairment in physical, learning, language, or behavior, these conditions begin during developmental period, and they impact day-to-day functioning. So when you think of developmental, you think a condition that occurred early in a person's life. Now, there's also another disability called intellectual disability. And this one is characterized by significant limitations in both intellectual functioning, but also adaptive behavior as well. So, for example, you could have someone with a developmental disability who may not have an intellectual condition. Whereas someone with an intellectual disability, what you're seeing there is someone that has a different IQ at a certain level, but also the adaptive behavior is key to being able to diagnose that. So what we're looking at the ARC is specific to IDD. And as we began to talk as a team through the academic training project about the importance, the supreme importance of peer support, and thinking about how to bring that into co-response. Of course, since our team is looking at all types of disability from mental health conditions to IDD, we started thinking about this topic as well. Now, in this field specifically, we have seen peer support on the rise, and we see peer support happening in the IDD field, but we haven't seen it happen in crisis response more specifically. So we don't have examples to share yet, but as I said, we see that people are working in this. For example, there's a peer support network that's national that's being created out in Boston, Massachusetts, where they're looking at how to equip people with IDD who are sexual violence survivors to support others who have gone through similar experiences. So we see this in bits and pockets throughout the country. But again, you know, one of the key issues that we're looking at is how do we create systems to allow people with IDD to be able to be paid peer support specialists. Essentially, when we look at different billing structures within states, we see that there really isn't a structure for that for people with IDD. And even when people with IDD can get paid for doing this type of advocacy work, there can be fear of losing their benefits, because if they make a certain amount, then they can't have their benefits as well. So that's an ongoing problem that people with IDD face as they look at becoming consultants on different projects, as they work as peer support specialists. And then typically, people with IDD can become a peer support specialist, but only if they already have the co-occurring dual diagnosis of IDD and a mental health condition. And that was actually Jordan's case, who you'll be hearing from in a second, in that he became a peer support specialist when he had the mental health condition diagnosis, but it wasn't until later that it was found he also had an IDD. So that kind of was what inspired him so much to be doing this work, when he realized there's a whole nother population of people that we're not opening up to in order to allow them this kind of opportunity to do peer support as well. And then we do need a standardized and sustainable model of supporting people with IDD in peer support work and other crisis response roles as well. So that is kind of our hope in having this conversation with you today. And I did want to put in the chat real quickly. Let me see here. I don't see where I can send it to everyone, so I'm going to send it here, and then hopefully it will get sent to everyone. Just some of the different resources that have to do with peer response and people with IDD. We were involved in a Taking the Call conference that was supported by BJA, where we were able to bring topics around IDD and co-response as well. And then just some resources around understanding the differences between IDD and mental health conditions. So now I'd like to introduce Jordan, which you kind of already had his introduction, but Jordan has been so great to work with us on this webinar today in bringing kind of his own lived experience around working as a peer support specialist in Texas. And so Jordan, if you can unmute and just tell us a little bit about how you became a peer support specialist.
Okay, sorry, my internet went out for a second.
Well, you're here now.
Are we at the point where I'm talking about how I became a peer support specialist? I'm sorry.
Yeah, that's it. Please tell us.
Okay. So through lots of research and finding the correct people to talk to, because in Texas, long story short, Medicaid wasn't always billable peer support. So we had two separate certification entities. And then when we had the Medicaid billable stuff passed in the 2019 session, then it all merged. And so it was just basically a lot of figuring out who I am supposed to talk to, and then finding the people that were able to answer my questions in a way that I understand.
And then as a peer support specialist that has an intellectual disability, why do you think it's important to include people with IDD specifically in peer support?
All right. I think I'm gonna have to join from my phone. Wait, can y'all hear me now?
Yes, it's working now.
Okay.
Go
All
ahead.
right. I'm on my hotspot right now. Um, so so it's important to keep people with IDD and peer support because they can actually benefit from peer support services because a lot of the challenges people with IDD face have to deal with the social skills aspect. And so having that person who understands what you're going through and is able to relate, it kind of helps being able to get the support that you need.
And Jordan, someone mentioned in the chat that you might want to turn your camera off. That might help with so you're not going in and out. So try that for a second. And then
Okay.
how does having an IDD make you more effective in your current job? Can you talk a little bit about that?
Yeah, so being co-occurring with IDD and mental health, I actually know of more resources than my coworkers, just because there are challenges that I have had to navigate that they haven't had to navigate. Um, and so I'm more aware of potential resources and programs to support people with disabilities because I have disabilities.
Yeah, great point. And as we're thinking about any challenges that you may have experienced, can you talk a little bit about maybe challenges that people with IDD might face if they're trying to become a peer support specialist?
So for me, one of the biggest challenges early on was figuring out how to become certified.
Okay.
Because when I first started this journey, the first agency I reached out to pretty much said, if you really want to be certified, then you'll figure it out on your own. And that was not helpful at all. So finding the right person to talk to, and then another challenge might be figuring out how to advocate for your support needs. And then of course that also means sometimes you might struggle with identifying what your support needs are, but these are all things that it might take a little more effort depending on I'm trying to stay person-centered with how I say this. So depending on how, I guess, how your disability impacts you can influence how much of a struggle it might be to identify your support needs and then get them met. So I'm not saying it's impossible, but I'm also saying at the same time for some people with IDD, it's really easy. And for others, it's just really a struggle. But if they're provided the proper supports, it's not impossible.
Yeah, well said. I mean, that makes total sense, Jordan. And one of the other things we talk a lot about is accommodations and how people with disabilities need different accommodations. And I think you and I talked about that in preparing for the webinar today. Can you just tell us one or two accommodations that have helped you either in the certification process of becoming a peer support specialist, or that just help you as you do your activities?
So working part-time is an accommodation I have at my job because we tried full-time and I just can't handle it, both because of my processing information challenges, as well as part of my physical disability because I wear leg braces as well. And then when I was actually taking the exams to become certified, I had a time and a half. And then instead of reading the test myself, I had someone that read the questions and all the answer choices. And they did that for every test or for every question. And that's how I ended up passing.
Got it. Thank you for that. That's important for others to hear. I think just the type of accommodations can really be helpful for people with IDD who are wanting to do what you've done. So another question we have is more about co-response. So once we do have more opportunity for people with IDD to become peer support specialists, how do you think they could be integrated into crisis response or to co-response teams?
Well, first, you need to really make sure that the person has at the point in their recovery where they're not at risk for relapse, because really the last thing you really want to do when you're trying to support someone is partner them up with someone and then that person relapse, because then the person that's supposed to be supporting the person has relapsed and therefore can't really provide the needed support. But I think once the opportunity arises and you make sure that the people that are providing the support, are foundational in their recovery and like not high risk for relapsing by supporting someone in crisis, then it could work. Whether it be like going out on crisis with police or mental health team, I think going out with the mental health team would probably be better, just because typically individuals with IDD experience a higher rate of trauma than those without IDD. Therefore, having them where there is police response might be higher risk of issues.
Yeah, great point. And I think something else that we had talked about was how people with IDD might know different resources in the community. So do you think that's one thing that you could bring as a peer support specialist in a co-response situation, just knowing different resources?
Yeah, that's kind of how people with IDD would be most helpful really in a crisis situation, because typically when you're in crisis, or at least in my experience, I'll put it that way, when I was in crisis, most of the time it was because I didn't have the resources that I needed. And I was struggling with finding them. So having someone with IDD go out and support people in crisis, especially if the crisis is, simply that they're just having a hard time finding the resources they need, then, that's where the individuals with IDD could be very beneficial.
And one of the things you mentioned too, you said that having someone with an IDD on the scene, like during a crisis situation, is much more comforting because you don't feel so alone in what's happening. So I think you said something about not feeling as intimidated, and that people with IDD may be more likely to speak up, to speak out, and to feel safer to talk. Do you think that that would be kind of a key support role as well?
Yes, because for some people with IDD, like my girlfriend, who has autism, some people with IDD and autism or other forms, they'll leave out keywords like verbiage or pronouns. And so to someone without IDD, it could be a little more challenging to understand what the person is trying to share. Whereas, other individuals with IDD that have that exact same challenge understand perfectly what the person is saying. Like, there is like no miscommunication, and then might be able to help interpret what the person is saying to
Got it.
those that don't have IDD, so that way the person in crisis could get better support.
Right. And I think we talked about, even if someone with autism, for example, is stimming, then that's not seen as an odd or strange behavior, because someone else who has similar behaviors, to them, that's just everyday life. So bringing that to the table, I think, really keeps, kind of can de-escalate a situation right off the bat. So I have one last question for you. If you could become part of a crisis response or co-response team, do you think you might want to try it?
Maybe. I'm not sure. Well, because it's like, I've come so far since my last hospitalization, which was 2015. So almost a decade now, pretty close to a decade.
Wow.
And I really don't want to relapse, because, working on your recovery is like probably the hardest thing you will ever do, in my opinion. And so while I do enjoy supporting others, and it's actually therapeutic for me to support others, I'll also have to be mindful and make sure that I'm taking care of myself. Because if I'm not taking care of myself and I'm putting myself in situations where it might be, for me, high risk of relapsing, then I'm not really doing my job as a peer support specialist. Because I did, for example, when I first started my job that I have right now, back in March of last year, I actually had a peer overdose over the phone with me. And they actually went unconscious while on the phone. And the person that was with them did not want to give us the full address. But I guess because they were fearful of getting arrested. But thankfully, eventually the police found the peer, and the peer got the support that they needed. And as far as I know, the peer is still alive. But, when you're talking about crisis response, you also have to keep in mind with peer support specialists that once you make that initial contact, sometimes the person being supported can have a little bit of embarrassment feelings. And, once they're stabilized, they may not want to continue working with the peer that supported them in crisis, because the peer that overdosed over the phone with me didn't want me as their peer specialist once, they were recovered. And that was something that my job respected. And so that was just a little bit of 2 cents around making sure that, if we're supporting people in crisis as peer specialists, and then they kind of expressed wanting a different coach.
Yeah.
So.
I don't know, Jordan, if you're seeing all the comments that I'm seeing in the chat, but everyone is so grateful that you joined us today, and so grateful for all the work that you're doing as a peer support specialist in Texas. Just kind of the example that you're setting for other people who want to do this work. Another key issue in the IDD field is that the employment rate is so low. And it's important that we pay people that have expertise, have a desire to help others in this way, that they have a way to get there. And you are a great example of that. So we thank you so much just for your time today on the webinar. And I think that our part is done, and now we can hand it over back to Mike, I believe.
Yep. Thank you, Leanne, and thank you, Jordan, and thank you to all of our presenters. So we have some time for some question and answer. So if you do have questions for our presenters, if you find the Q&A button on your screen, and you can click on that and you can pose your questions to any of our presenters in the Q&A, and it is different than the chat. So if you have questions, please put those in the Q&A, and we will get through some of those now. And I do have a couple questions already up here. The first one is for Chanson Neither, and it comes from Pat Willard in California. I appreciate the explanation of the sequential intercept model. I've seen it before, presented as how a clinician embedded with police crisis response would work. Although I was told not to think of it as a flow chart, my interpretation remains that what it shows is that a mental health crisis is considered criminal by law enforcement. Looking for your thoughts or input on that, Chan.
Sure. Sorry, it took me a minute to get off of mute here. So I appreciate that question. Thank you very much. And I'll say that the intent of the model is very much not to present or get to give that impression. In fact, one of the things that we added to the model in 2017 was actually that first intercept 0. And one of the main drivers of adding that intercept to the model was to acknowledge that there, in many communities, is often a very robust crisis care system, crisis response system. In many communities, it's not as robust, but that there are crisis response and crisis support services often available to people in the community that can prevent penetration at all into the criminal justice system. Some people use the term deflection to represent that. So we very much use the model to depict how a person can become involved with the criminal justice system, the criminal legal system, and progress through the criminal legal system. But the point of really talking or of having different intercepts and talking about strategies at different intercepts is to identify and interface with a person at the earliest point possible during crisis, ideally prior to any law enforcement involvement, and certainly prior to any formal law enforcement context, such as an arrest. So I hope that answers your question, but feel free to ask another follow-up question if it doesn't.
Yeah, I think it's important too, Chan, to note that, you know, regarding law enforcement and criminal in the sequential intercept model is that it allows law enforcement to step back into intercept 0 and divert or deflect some of those things that may be going on from, you know, trying to guide a person out of the criminal justice system and utilize those resources, those community-based resources ahead of that. And that's where intercept 0 came back in 2017, was it? 2016?
2017.
Yeah.
Yeah, absolutely.
So, and I think this kind of, I think you may have answered this next question, but how can and does the SIM integrate deflection programs and strategies at intercept 0 and 1? I think that was probably answered.
Well, yeah, exactly. I mean, that's the, like I said, with the addition of intercept 0, it's really recognizing that there are a lot of opportunities to prevent people from having contact with the criminal legal system in the first place, and that's really where the focus of deflection efforts, you know, is typically sits within that model.
Absolutely. So, thanks, Chan. A couple of questions for the Heart team. First one is, how do your different teams, co-response mental health teams versus peer clinician teams, coordinate with each other for individuals who come in contact with both teams for different types of calls?
We actually spent a number of months working on assuring that there was good collaboration. We did very regular meetings with both teams for the adults to make sure that we had a good differentiation of who covers what types of calls, and the fact that the state team was already in existence for a good 19 years. And it was very well known to be the much more critical situation. So they will go out to situations that might include some violence, some aggressiveness. The CRT team will not. And we just, you know, the state team has the ability to compel someone to the hospital if they need to. So most of the situations that are coming in for CRT are not in that at that level of intensity. And so therefore we were able to kind of differentiate between the calls in terms of what types of call types a bit more through discussion, through case review, but also just through the established relationships and team members.
Okay, thank you, Patricia. Another question for you. So in Hartford, did dispatching increase staffing in order to handle the increased calls in dispatching the HART team? And as a follow, the second question is specific to where did the funding come from, if so, but maybe you can touch on how you funded the HART team in general while also answering that other question.
Sure. So the HART team was a concept that was created by our mayor back in early 2020 in terms of wanting to identify what type of civilian crisis response team we could provide. And certainly the events of 2020 escalated the need for that. But through COVID, we saw some savings for the city of Hartford, and he was able to capture some of those savings and redirect that funding towards this initiative. So very different from some states that are starting without any funding support. We started with funding and needed to determine how to meet the needs of the city, as opposed to starting without any funding and needing to figure out how are we going to fill what we develop, how are we going to fund what we develop. So that's a funding piece. It came from savings that we recognized through the COVID period when people were not seeking all the services that we were offering through the city. The other part of that question around the increase in staffing for dispatchers, actually, as you know, we've all been in such a staffing crisis. We did not do there was no need to increase additional staffing to the dispatchers. And from my own knowledge, I actually verified that information with the dispatch director as I saw that question come in, because I wanted to make sure that I was accurate in saying that there was no additional funding identified. There were several vacancies when you initially started this program, and there's been a shift of, through all of the disciplines involved, there definitely has been a shift of engagement. So sometimes we are finding that we are hiring a few more peers, or we're hiring a few more clinicians, or we're hiring a few more dispatchers, just because of the flux of change that we're seeing in all disciplines across the United States. But no, there was not additional funding identified or additional staffing requirements.
Okay. Another question for the HART team, as far as convincing law enforcement to adopt peer strategies. Do you have any ideas or suggestions how to sway the naysayers?
How to sway the naysayers? Our law enforcement team was not the naysayers. They were very engaged from the very beginning. They were a part of the advisory board. Our fire was part of the advisory board. EMS was not, just because EMS is differently funded throughout the city of Hartford. However, they were definitely brought into the table as we decided to launch. They were part of the implementation team. I would say that our naysayer was fire more so than police. But I think the things that really helped our team, the established relationship that we already had, I can't say enough about how that already kind of laid the framework. And that was really working just Hartford Police and our mobile crisis team through the state. Even fire wasn't even aware of that relationship. Dispatch didn't know how it worked. It really didn't. It happened in its own little vacuum. But what we did is we took that out of the vacuum and we made that a dispatch process, so it was more globally understood and embraced. In addition to that, as part of the training, that when we were initiating the use of clinicians and peers specifically, we definitely did ride-alongs, we did roll calls, we introduced the services. And more recently, as we're about to launch a component working with fire more directly around substance use and overdoses, we introduced the concept to the fire department. And initially there was some resistance, and as we broke down that shell of who the peer is in this situation and what the peer can bring to the table, it was so palatable in that room to see this entire kind of dissolution of that framing, that arming, that guarded stance of fire to, oh, you have lived experience. You're even more clued into this than we are, and you really probably could make some headway. And all of a sudden, you could see the buy-in happening. So that's part of what's happening in the community in terms of building relationships with our safety departments, our public safety departments. It's all around building relationships and kind of breaking down some of those barriers to getting the care and judgments and and things that we carry with us. And it's just remarkable to watch it. So I think that is a really critical piece. It's just about people learning each other and recognizing the strengths of relationship.
Awesome. Thank you. A couple of minutes left. So a couple questions for Leanna and Jordan. Do we know how many agencies had peers with IDD?
Sorry, I was muted. And Jordan, feel free to jump in too, because you know more about this in Texas than I do, even though I'm in Texas. Are we talking about peer support in specific situations? To my knowledge, I don't know that we have data on that, where we have national data that tells us like how many are hired, by certain behavioral health agencies. I think this is still somewhat so new that we're trying to figure out payment streams that would actually allow people with IDD to have this opportunity. And that's something that Jordan, you can pick up here. You and I talked about this just in terms of how would someone with an IDD even be able to get a certification on this? So do you want to talk about that as well?
Yeah, that's actually another question in there. Is somebody with an IDD, how would you, how do you get the peer support certification?
Okay. So I don't officially know of any other peer specialists in Texas that have IDD as far as like working for a MCO like MetroCare or Harris in Houston. But I do know Harris in Houston has started offering IDD peer support services because they did have a posting a couple of months ago. I know I'm involved with a IDD peer support project here in Texas that actually ends in March of next year. Hopefully that grant will be renewed so we can continue our work. And then I'm actually working on getting an IDD virtual group up and running at my job that's been approved. But as far as certification, there have been a few projects done in the recent years here in Texas around that topic. And it's ironic that y'all ask about that because I'm actually working on a bill to get it filed in the 2023 Texas legislative session that would essentially identify what the certification would look like and the training requirements and all that kind of information. So while it's not necessarily like officially in existence per se, there are organizations within Texas that do offer the peer support services. It's just not a state recognized certification that they hold yet.
Okay.
So hopefully that answers y'all's questions. And maybe if I email one of y'all in the chat, y'all could post my email where everyone else could see it. So if they have more questions, they could reach out to me. Because I can't post in chat to everyone. I can only post to panelists and hosts.
Yeah, we'll be glad to get the contact information out to everybody. So thank you so much, Jordan and Leanne. One final question, and this question goes to Stephanie, and it's a quick one. We've got about 3 minutes left. But Stephanie, in your experience in peer support, have you seen any change in influencer behavior as far as police behaviors when you're on a call?
They're very receptive to us. They honestly, they love us because they now can take care of the more right? Police immediate calls, and we can worry about the emotionally distressed, loitering, mental health, substance use. So we're basically alleviating some work for them, and they're very happy with us.
Awesome. Thank you, Stephanie. That's going to conclude our Q&A session. We're just about out of time. So again, I want to thank you, thanks to all of our panelists. Thanks for the chat. There's a wealth and plethora of information in the chat from all across the country of organizations that are getting up and running, organizations that have experience with this type of work. So thank you so much for being an engaged and interested audience. Presenters, panelists, you did an amazing job. Thank you so much for your time today to present. There's a lot of follow-up information that folks are asking for, so we'll make sure that the contact informations are out and available for everyone. And just as a closing real quick, if you'd like to learn more about the academic training to inform police responses, our website's on here. You can access it through the International Associations of Chiefs of Police, or you can access it directly through informedpoliceresponses.com. Again, the academic training to inform police responses is it's a BJA funded program. It's made up of the University of Cincinnati, Policy Research Associates, the ARC of the United States, and the International Associations of Chiefs of Police. And on behalf of all of those organizations, thank you so much to everyone for being with us today. And this information, the recording of this information, and any of the handouts that we had will be available and sent to the participants of this webinar at the information that you provided during your registration. So thank you so much, everybody. Have a great day.